It's a great pleasure to welcome you all for the today's session, Current Oncology Updates Series 10. So I would like to invite Dr. Rajat Bajar sir. He is a Director Medical Oncology IOCI Fortis Hospital, Noida. So it's over to you, sir, to give us a welcome note.
Yeah, I hope I'm audible. Good evening, everyone. I thank everyone for joining in this evening for this two-day oncology update that we are going to witness. And these 2 days, we are going to cover the newer updates that have come in the field of oncology. Broadly speaking, medical oncology, be it the subsites of lung, breast, GI, or prostate malignancies. We all would agree that as clinicians we have to be abreast with what is ongoing in our field so that we can give the best to our patients in our clinics, and that is what the endeavor is when we organize such meetings. And I'm sure that the active participation from all the attendees would certainly make it a great success. So without any further delays, we would be starting with the biomarker session in early lung cancer. We all know that lung cancer has been the poster child of the molecular oncology or precision oncology in the last decade or so, but always it was in the metastatic setting. But now there are newer advances in terms of biomarker space which have come in the early lung cancer as well. To discuss the same, we have Dr. Vamshi with us, who is the head of genomics and clinical cytogenomics in Delhi. So, Dr. Vamshi, please take it forward. Good evening.
Thank you, Dr. Rajat. Very good evening to you and very good evening to everyone. I think I'm dealing with a very important topic here, the early biomarkers in the early stage lung cancer. Let me just share my screen. Please let me know once my screen is visible. Is my screen visible? Can everyone see my screen?
Yes, sir.
Yes, it is visible.
Okay. So my topic is on actionable biomarkers in the early stage lung cancer. So when we talk about biomarkers, what are the molecular biomarkers? These molecular biomarkers are biological indicators. They obviously give us an indication whether a specific biomarker that we're looking for in a specific tumor is it present or not. And it must be accurately measurable in any of the feasible samples. It could be pleural fluid, it could be urine, it could be CSF, it could be peripheral blood, which is one of the most common sample type that we use. These biomarkers, when we measure them, when we quantify them, they should be reproducible. And most importantly, these should be cost effective. So they must be used. We should have a use case scenario in the masses. As I was mentioning, it's not just the peripheral blood. There are other sample types also, like other bodily fluids, like saliva, urine, pleural fluid, sputum, bronchoalveolar lavage, etc., wherein we should be able to check these biomarkers. At present, there are certain exhaled breath biomarkers also present, wherein those nanoparticles is what we are measuring to kind of look at the mutation burden or the specific biomarker burden in a tumor. Why would we want to do that in early stage lung cancers? There's room for improvement in disease-free survival rates, which has been seen in the various studies for the early stage lung cancer. And these biomarkers are better. They better characterize the risk of any indeterminate nodules that we see, especially in the early screening part. They refine the prognosis. They give us the risk stratification of the staging of the disease, and they help in the management, of course, the treatment of these detected tumors. The international adjuvant lung cancer trial, some certain trials from the US, from the Canada, the ANITA trial, they obviously reported a benefit in the median survival as well as the disease-free survival with adjuvant chemotherapy in early stage lung cancers, which is the reason why in early stage lung cancers, the biomarkers are obviously what we call them as actionable. There are certain commercially available biomarker tests, and some of them are here. I've not mentioned the third one, but early CDT lung is based on auto antibodies, and Notify XL2 is based on certain clinical as well as genomic parameters. In the serum and plasma, if you look at certain antibodies, we all know that these are the autoantibodies that we look at in specific cancers. They are not specific to any, but they kind of give us the mutation burden. CEA, CA125, P53, KH, SOX2, NSE, C4D. These are the specific autoantibodies that we see, or the proteins that we see in the serum or in the plasma. MicroRNA is very well talked about. These microRNAs are very stable as against the cell-free DNA. Cosmos 2 trial has used 13 microRNA signature and 6 for normalization. There is a signature of 2 microRNA. The MIR test, which is a signature of 13 microRNA. There's a signature of 14 microRNA. There's also microRNA signature classifier, which is used for ratios amongst 24 microRNA that are specific for early stage lung cancer. How about DNA methylation? The SHOX2 gene and the PTGER4 DNA methylation are specific markers for early stage lung cancer. And there is also the circulating tumor DNA, which is the most common sort of biomarker test which is available these days, which is most commonly reliable, in our clinical setups, which detects early stage lung cancer. There's been an analysis of 11,787 CPG sites across 595 regions in the human genome. And these CPG sites are looked at for DNA methylation. And it's called as the PAN-SEER assay. The PAN-SEER assay detects early stage lung cancer DNA methylation sites, especially of these 11,787 CPG sites. There is also, as I mentioned earlier, the circulating tumor DNA, which is the most common, most abundant test that we perform these days. It's not only for the advanced lung cancer, but also for the early stage lung cancer. These are all the validated tests, other tests which are undergoing clinical trials and validation. A signature of 29 mRNA genes, which is one of the most commonly studied, or which has a very good 15,000 more than 15,000 participants which are there in that particular trial. And also a tool called lung cancer likelihood in plasma, the lung clip. It integrates ctDNA findings with other molecular features. And this can help our patients to get risk stratified, and they kind of get benefit from the adjuvant chemo as against somebody who's got a placebo, in those specific trials. Fragmentation patterns of circulating cell-free DNA has also been a useful tool to detect the lung cancer, an early stage one. Not just the peripheral blood, but also from the bronchoscopic specimens, the sputum, the breath, and the urine, etc. All of these biomarkers are showing promise as being the early, markers in the early stage lung cancer. As I was mentioning earlier, the DNA methylation markers, microRNA, which has very promising results, the chromosomal aberrations, exhaled breath. In that breath, we are looking at the nanoparticle biometric tagging. Tumor cells, if there are tumor cells that we are isolating from these, all the different specimens, the circulating tumor cells, if they are more than 700 is one of the trials which is being looked at. And obviously, in the urine markers, some certain metabolites are looked at in specific trials. Few trials also look at not just peripheral blood, not just a bronchoalveolar lavage or a pleural fluid, a mixed array of these biospecimens. The biomarkers are being tested for. The microRNA gene expression or the mRNA gene expression and the proteomic, apart from the transcriptomic signatures, are looked at for these early stage lung cancers as to how they kind of can help out in the adjuvant chemo. One of the tests that I was mentioning, which is commercially available, is the early CDT lung. So this has been studied for clinical validation in several cohorts of patients in a newly diagnosed or the early stage lung cancers. This is based on autoantibodies. It has a specificity of about 90%, but a sensitivity about 40%. And this is a commercially available test for early stage lung cancer. What about other than autoantibodies? There is a 13 protein proteomic classifier, which would give about 90% negative predictive value for being a benign nodule. And it might not be, something which is an early stage or an invasive or a metastatic nodule that we're looking at for benign nodules. And how about for a 5-marker subset of the original 13 proteins, along with the 6 normalization markers? That's another study which is going on. And these are the proteins other than the autoantibodies in the blood. The second commercially available test which combines the clinical risk factors as well as the genomic protein signature is the XL2 test. This test has a classifier wherein two proteins, the LG3BP and C163AR, which are independently linked to the lung cancer and inflammatory response to lung cancer, respectively, are integrated with 5 clinical risk factors in the form of where is the nodule located, peripheral versus central, what is the size, more than or less than 3 centimeters, is there any speculations in that tumor, what is the patient's age, and is the patient's smoking history positive or negative. These are the various clinical risk factors which are combined with the two proteins, and a classifier is developed and it is available commercially as a test called as the XL2. As I was mentioning, the liquid biopsy is not just a circulating tumor DNA. Liquid biopsy is circulating tumor DNA or circulating tumor cells or exosomes. These exosomes are stable, much more stable than the circulating tumor DNA. The circulating tumor DNA has to be isolated within 1 hour of collection from the patient if it is in a hospital setup. Or if we are collecting it in a strect tube, that kind of stays okay for about 5 to 7 days. However, these exosomes are stable even in a room temperature. They can be easily collected from any of the body fluids like the circulating tumor DNA, from the peripheral blood, from the pleural effusion, from the bowel fluid, from urine, sputum, CSF, and all of these body fluids contain plenty of exosomes. And these exosomes are mostly contain the microRNAs. And these are very good concentrators of whatever the biomarkers that we're looking at, whatever the molecular signatures that we're looking at from that specific tumor, and which is present in the circulating tumor DNA in a not really much of the mutation burden. There are certain, these are the suitable candidates for liquid biopsy apart from circulating tumor DNA and the circulating tumor cells. And diagnostic studies, obviously, related to exosomes have mainly focused on microRNA, and these are very abundant concentrators of microRNA, the exosomes. So, which is why this is a very good, promising future that the exosomes or the microRNAs have for early stage lung cancer, or for that matter, any other liquid biopsy. These microRNA signatures have been present, especially in non-small cell lung carcinoma from 2009 onwards. But they've not really come into clinical diagnostics. They've been knocking on the door of clinical diagnostics, but they're more into the research. And most of these microRNAs come up in the form of panels, not a single microRNA, single microRNA as such, but panels of these which come up for and have been proposed for non-small cell lung carcinoma from various sample types that they've been isolated from. An exosomal MALAT1, which is a long non-coding RNA, certain double-stranded DNA, certain microRNAs and mRNAs, certain mRNAs are also considered as exosomic signatures for the tumor, for the early stage tumors. These mRNA signatures, the messenger RNA signatures are being also studied. These messenger RNA studies or the transcriptomic studies can be done when we know those particular signatures. These signatures, when we know, it is very easy for us to quantify them either in a chromosomal SNP microarray or in a quantitative PCR. And these gene expression studies, these mRNA gene expression studies have been studied, and there is a 23 gene classifier which is available for non-small cell lung carcinoma. So to summarize, the early stage lung cancer biomarkers that are available or that are being are promising, which are coming up in the near future. If we combine the clinical features, if we combine what we have right now as the LDCT with the molecular biomarkers that I've just mentioned, I think it would be very good for the survival improvements, not only in advanced stage lung cancer, but also for the early stage lung cancer, non-small cell lung carcinoma patients. Thank you for your patient listening. I'm open to questions now.
Rajat sir, are you there? So thank you so much, sir.
Thank you.
I think the register is stuck in OPD maybe. Okay, so thank you, Dr. Vamshi. And next speaker, I would like to invite Dr. Udip sir. And to give his talk about newer treatment option for EGFR mutant NSCLC. So it's over to you, sir.
Need permission to share.
Yes, you can, sir.
Yeah, can you see my slides?
Yes, I.
Sure. Okay, so today we'll be speaking about anti-GPR therapy, what's new. So we'll be only touching on the newer aspects that have been discussed and probably yeah, the newer treatments that are available and what we need to do. So as we all know, the prevalence of EGFR mutation in Southeast Asia is increasing. In India, the prevalence is quite high, and that is why EGFR has always been in context. And one second, just one second. Okay,
So make it full screen, please.
yeah. Now is it visible? Yeah.
Yes, sir. Move
Yeah.
ahead.
Sure. So, target therapies, in all of lung cancer has been evolving, and as you can see in the cartoon, that most of the trials have happened in EGFR initially, then ALK, and then ROS1. So EGFR has a lot of data to back up and a lot of newer therapies that are there. So moving on, we know that TK and so major discussion this year is whether osimertinib single is it good enough in frontline, or should we do something else along with osimertinib. So with the advent of trials like Flora 2 and Mariposa, and also the other trials like the Amigo HS 10241, which is another anti-EGFR amlodipine, which is a Chinese drug and has shown benefit with chemotherapy. Uh, and also nowadays trials of EGFR TKI plus ADC is ongoing. So are these is the need of the hour to add some therapy to EGFR? How do we quantify that? Let us look at that in these lines of therapy, right? So we know that rationale is that drug persistent disease, that is the can only single agent osimertinib can give rise to various mechanisms of resistance, and these resistant clones then overall develop and get transformed into some refractory disease to osimertinib. So nowadays, targeting these mutations, as in not the mutations per se, but targeting with therapies which avoid generation of these mutant clones, is something which is need of the hour, and that has been studied in the last 3-4 years and has been presented here in WCLC also. A lot of these data have been presented where osimertinib needs to be combined with something for treatment, right? So next, coming to the next, so clinical relevant evidence gaps in the frontline treatment of patients with EGFR mutated metastatic lung cancer. So we know that there are many attempts to combine EGFR chemotherapy, and they were not successful in the past. And then we know now with the TMH trial that was done, where gefitinib was combined with chemotherapy, and that did show a prolonged PFS and OS versus gefitinib alone. So this one trial, and also there was a Japanese trial, I remember, that also had shown a significant benefit of combining gefitinib with chemotherapy. So updated analysis showed that uh, in another phase 3 trials, there was no significant OS difference in gefitinib versus this. But however, I think beyond the standard osimertinib monotherapy, the emergence of new combination challenges for treatment selection. So FLORA is again osimertinib, PFS was 18.9 months. FLORA 2 with osimertinib and chemotherapy has shown a PFS of 29.4 months. Mariposa again is a lazertinib, which is similar to osimertinib, third generation drug with amivantamab combination shows 23.7 months of PFS, which is significantly higher as compared to single agent osimertinib, which was seen in FLORA. So coming to the OS benefit observed in the OS benefit trend, which is observed in FLORA 2 is good. HR is about 0.75 and is persistent till now. So this is one. Second is the open question is that determining which patient needs upfront treatment, intensification, integration of novel biomarkers into practice, and optimal management of CNS metastasis are the three key areas which needs to be thought of when considering combination of osimertinib or combination therapies in the first line EGFR mutant. So potential factors supporting intensification for frontline treatment is a mutation in L858R, which is shown that del 19 mutations are better than this. If the performance data is good, two mutations like P53 is there, CNS metastasis is there, as FLORA2 has shown definite FLORA as well as Mariposa both have shown the duration of CNS responses are more prominent and significantly higher in both the trials. Symptomatic patient, high tumor burden or ctDNA, that could be one of the ways we treat our lung cancers now. Is there a need to define a specific threshold for high tumor burden, and are there any emerging indicators? So can we see? So again, if you see FLORA2, so EGFR mutation, both exon 19 L858R showed similar benefits. Even CNS metastasis, if it was yes, it was see. If you see the forest plot, it is very significant. Again, in Mariposa, similar liver metastasis at baseline, uh, detectable baseline ctDNA at NGS, and T53 co-mutations, all of them derived similar or even better benefit as compared, in the trial. So it is well known that TP53 co-mutation with single agent osimertinib does not show that much benefit, and that is where we are. So yes, I think all these factors that we discussed in patients with in FLORA2 and Mariposa did show benefit in all of these. So many clinical trials. So for the challenges considered for CNS, which is an important factor, is that many trials do not screen for CNS metastasis, and patients with asymptomatic or untreated CNS metastasis are excluded in most. So, but in FLORA2, patients with asymptomatic stable CNS metastasis were allowed, brain imaging mandatory at baseline, and brain imaging performed in all patients at baseline, and scheduled assessment on progression for patients with baseline CNS metastasis assessed by BACR. So that was done, and if you see all the lines are below the zero line, and that shows that the CNS response rates are very durable and long, and you can see the separation of the graph in the FLORA2 trial, and obviously the HR is significant, right? So control also similar in Mariposa with lazertinib and amivantamab, the response rates were good, and even the median time of treatment was good. So both of these patients showing, in fact, in the brain mets and leptomeningeal mets also, both of them showing good percentage of response rates in combination therapies. So control for observed in ADC. So also one more way we treat our patients is ADC. The two ADCs that are there, the Destiny trial, and Dato-DXd, which is coming up in a big way in lung, these also show responses in brain, and that also is one of the ways to target the brain. So the Teliso-V, which is a MET, it is a MET mutant for patients with EGFR mutation, where they've used Teliso-V plus osimertinib, and that also showed a good response rate in such patients, right? So these trials support the use of uh, osimertinib along with something. And similarly in Tropion lung trial, that is for Dato-DXd, again, and also in the HER2 HER3 DXD, that is the Destiny trial, also showed the same, right? So coming to Flora 2, the last the way we are going to treat is detection of baseline ctDNA, and if the ctDNA was detected in plasma, the obviously the PFS was slightly lesser, and if you see the osimertinib monotherapy and where detected plasma, if it's a uh, non-detected versus detected, if you see the separation of curves is wide versus CTX. So it does help that intensifying therapy in patients who have a baseline detection of ctDNA with osimertinib and CTX. Right, so baseline ctDNA is prognostic, but also somehow predictive. Means the need of the hour is to get more trials to do this. However, if you see the analysis from Flora 2, it does show that higher degree of clinical benefit is observed with OSI plus CTX versus OSI alone. Right, so it does serve as a surrogate of several cancer factors, ctDNA. Correct. So now can we plan a trial where we classify with ctDNA persistence OSI, give OSI, see if there is a ctDNA clearance in 3 months or 2 months, and then summatinib can continue if it is cleared, and if it is persistent, then you can randomize into two. So coming to also see if seeing the mutation profile for Flora 2, where monotherapy, and Flora where osimertinib monotherapy was used, versus a Flora 2 where platinum was used with this. You can see classically the MET amplifications are less, the EGFR mutations, the number is less. The even the MAP kinase PI3K pathway are less, fusions are less. So obviously it leads to lesser secondary mutation generation if chemotherapy is used along with it, which is very logical. And correct. So now, lastly, the other thing that is new, we've been discussing in the last year as well. Exon 20 insertions have been very, very thoroughly discussed. I'm not going to go into detail on this, but yes, the amivantinib and chemotherapy does help, and you see the graph separating in exon 20 insertions, and that shows that gives us a very good use case scenario for amivantinib plus chemotherapy. And that's it. I think to conclude, who needs intensified therapy? Can we predict from outset or early on in the therapy who needs this? And as we discussed, clinical features, concomitant genomic alteration, ctDNA, and all needs to be openly discussed, and also OS data that might come now will help us. Clinical trials will address the best time to intensify treatment and start following maximal response at the time of resistance to osimertinib or at the start of therapy. So I think more clinical trials addressing this is required. That is the need of the hour. So thank you all uh, for your patient hearing. Any questions are welcome.
Thank you so much, Dr. Udeep sir. So is there any question? Okay, thank you, sir. So moving ahead for the next session. And so next session, I would like to invite Dr. Manish sir, and he's a medical oncology unit head, Action Cancer, to give us talk about peri-operative immunotherapy, a new frontier in early resectable NSCLC. So it's over to you, sir. Dr. Manish?
Yes, hello, good evening.
Hi, sir. Good evening. Can you present your session, sir?
Can you share the slides?
From my side, sir?
Yes, yes.
Okay.
So,
Sir, is it visible? Can you
yes,
please
yes.
open your video, sir?
My video is not working. Camera is not working.
Okay, sir. Move ahead.
So, good evening. Thank you for uh, giving me this opportunity, and I will be discussing about the peri-operative immunotherapy in early resectable NSCLC. Next slide. So, these are the outcomes in the resectable NSCLC, which still needs to be improved. So, the early stage NSCLC, that is stage 1B, there are 45% chances of recurrence or death. While the regionally or locally advanced disease with stage 2, the chances increases to 62%, and with stage 3 disease, the chances of recurrence or death increases to 78%. So, surgery with the curative intent is the primary treatment with the resectable disease, but still we have a lot of improvement, room to improve the outcome of our patients. Next slide. So there is still an unmet need, as we saw in the previous slide, to decrease the disease recurrence and to improve the survival in the resectable NSCLC. So earlier in 2005, adjuvant cisplatin-based chemotherapy was recommended as an adjuvant treatment because it showed improvement in the survival in the selected patients with stage 2 or 3A NSCLC, and selected patient with stage 1B disease, but the rate of the disease recurrence following surgery remains high across these stages, regardless of post-operative chemotherapy use, and hence the peri-operative regimen could further improve the long-term clinical outcome by combining the benefit of neoadjuvant and adjuvant immunotherapy to prime the tumor immunity while the tumor is still present and the micrometastasis can be eradicated. Next slide. So, neoadjuvant and adjuvant immunotherapy options, they have shown promising results with acceptable safety profile, and there are several advantages of the neoadjuvant treatment. It is more robust and durable anti-tumor responses against the micrometastasis can be there as compared to the adjuvant treatment. Potential for preventing immune tolerance and escape. Combining the neoadjuvant immunotherapy with chemotherapy further, adjuvant IO is expected to improve the activity and the long-term clinical outcome with the stage 2 and 3 NSCLC. And there is chance to treat patients who are not immunosuppressed. While with the adjuvant treatment, after the resectable disease, it has acceptable safety profile. It demonstrated the potential to restore anti-tumor immunity after surgical resection, leading to the immunosuppressed environment that promotes the tumor metastasis. Next slide. So these are phase 3 trial with immuno-oncology drugs in the resectable NSCLC, and these are the outcomes in almost all of the 6 clinical trial with nivolumab or atezolizumab or pembrolizumab or durvalumab or with toripalimab. All of them, they have shown significant improvement in event-free survival and disease-free survival. So today we will be discussing the Asian trial, which is the perioperative chemotherapy plus durvalumab in the patient with NSCLC. Next slide. So these are the various trials in various settings. Just for example, Checkmate 816 is the nivolumab plus chemotherapy 3 cycles followed by surgery, which has shown a significant event-free survival. Then the surgery followed by adjuvant immunotherapy uh, shown significant survival advantage with IM power 10 with atezolizumab in PDL1 more than 1%, keynote 091 in pembrolizumab more than for given for a year, which showed significant event-free survival. And similarly, there are few neoadjuvant trials as well, which one of which is Asian trial in which the durvalumab plus chemotherapy 4 cycles were given, followed by durvalumab maintenance. We will be discussing it in a short while. Similarly, keynote 671 with pembrolizumab plus chemotherapy followed by pembro 1 year, checkmate 771 nivolumab plus chemotherapy followed by nivolumab for 1 year. So these are various trials in the neoadjuvant space, adjuvant space, and the perioperative space. So the Asian trial which we are going to discuss is the perioperative immunotherapy option for NSCLC patients. Next slide. So this is the schema of the trial. This is phase 3 global randomized double-blind placebo control study. Patients, they were treatment naive with PS of 0 to 1, resectable NSCLC stage 2A to 3B, either lobectomy, sleeve dissection, or bilobectomy was the planned surgery. And these patients, they were randomized to chemotherapy plus placebo versus immunotherapy with durvalumab plus chemotherapy for 4 cycles, followed by durvalumab maintenance for a total of 12 cycles. So total 1 year of the treatment. And the second arm was the placebo, which was given for the total of 1 year. So the primary question here was, does the neoadjuvant durvalumab plus chemotherapy followed by adjuvant durvalumab, it improves PCR and event-free survival in the resectable stage 2 to 3B NSCLC compared with the neoadjuvant chemotherapy and placebo. Next slide. So these are baseline clinical characteristics of the patients. The median age was 65, 68% patients, they were male, performance status 0 to 1. The Asian patients, they were also very well represented, approximately 40% patients, they were Asian. Then the almost 85% patient, they were either current or former smoker. Stage 2 patients were 28%, 3A patients were 47%, 3B patients were 24%. And squamous histology and non-squamous histology were 48% versus 53.9%. 27% patient received cisplatin-based chemotherapy along with durvalumab, and 72% patient received carboplatin-based chemotherapy along with durvalumab. Next slide. And this is updated event-free survival in the intent to treat population. It favors the durvalumab arm, and the EFS was maintained and was consistent. That was reported previously. The EFS was not reached in the durvalumab arm versus 30 months in the placebo arm. And you can see the 3-year EFS was 60% versus 47% in the placebo arm. Next slide. And EFS benefit was maintained across all the predefined subgroups, irrespective of age, sex, performance status, histology, disease stage, lymph node stations, PD-L1 expression, or the planned neoadjuvant, either either carboplatin or cisplatin-based treatment. Next slide. So the benefit was observed regardless of the planned platinum agent, whether it was cisplatin or carboplatin. The benefit in the EFS was consistent. Next slide. Also, the pathological complete response and the major pathological responses, they were better in those patients who had received durvalumab 4 cycles preoperatively. For example, the PCR rates were 17.2% versus 4.3% in the placebo arm, while the major pathological responses were 33.3% versus 12.3% in the placebo arm. Next slide. So PCR was also significant across the subgroups, irrespective of the histology or disease stage or PD-L1 status or smoking. It favored durvalumab arm as compared to the placebo arm. Next slide. So this is the adverse event summary for the durvalumab versus placebo. All grade events were 96%. Grade 3 or 4 events were 42%. Grade three or four adverse events, possibly due to durvalumab, were 32%, and any grade immune-mediated adverse events were 23%, while grade 3 or 4 adverse event related to the immune-mediated adverse events were 4.0%. Next slide. So these are the most common adverse events of any cause. So most of the common adverse events were anemia, nausea, constipation, decreased appetite, alopecia, neutropenia, rash, and diarrhea. So you see the grade 3 or 4 adverse event, immune-related adverse event were just 3 to 4% in the durvalumab arm. Next slide. And the immune-mediated adverse events, the most common immune-related adverse events were hypothyroidism, dermatitis, hyperthyroidism. And the grade 3 or 4 immune-related adverse events were 3 to 4%. Next slide. So the stage 3 encompasses a diverse range of disease. Stage 3 can be because of the tumor size, it can be because of the nodal involvement. So it is a highly heterogeneous disease, and only selected patient in this stage will be candidate for resection, especially stage 3B. All stage 3 cases, they should be discussed in MDT, and they should be offered surgery if possible. Lymph node stations is possible, only then these patients should be taken up for the surgery, and these patients should receive neoadjuvant immunotherapy followed by surgery. Next slide. So what are the advantages of neoadjuvant perioperative versus adjuvant immunotherapy? So pros are highly because of the presence of the tumor antigen and the lymph node for the priming of the immune cells, better drug delivery due to preserved blood vessels, small tumor facilitates the complete complete with safety, high compliance rates, prognosis predictable by PCR. Cons are 15 to 20% cancellation of the surgeries can be there, increased complication, possibly the surgical difficulty can be there, needs preoperative biopsy to rule out the driver mutations, and the PD-L1 expression should be seen, and chronic risk of chronic adverse events, immune-related adverse events can be there, and financial toxicity, obviously, because we are giving it for a year. For adjuvant treatment, adjuvant immunotherapy treatment plan after the accurate staging and biomarker testing can be done, and no delay in the surgery will be there. While the cons is 30% of the patients after surgery never reach adjuvant IO treatment because of the deteriorating PS, which happens 50 to 65% compliance after 1 year. Next slide. So, which patient with stage 3 NSCLC may be considered for surgical resection? These are ESCO guidelines. For patient with stage 3A, that is N2 disease NSCLC, induction therapy followed by surgery with or without adjuvant therapy may be offered if all of the following criteria are met. So, number one, a complete R0 resection of the tumor and the involved lymph node, if it is possible. Only then these patients should be taken up for induction therapy followed by surgery. N3 station should always be checked, and they should not be involved by the multidisciplinary consensus. Perioperative 90-day mortality is expected to be low, that is less than 5%. For the patients with T4N0 disease by size or extension, the surgical resection may be offered if the medically fit and surgical resection is feasible as deemed possible by MDT review. Next slide. So these are the guidelines and recommendation from NCCN version 8 2024. The durvalumab along with the platinum-based doublet chemotherapy for 4 cycles followed by surgery, and then single agent durvalumab as a adjuvant treatment for 12 doses is a category 1 indication in those patients who do not have EGFR or ALK mutations. Next slide. So perioperative immunotherapy is a promising approach. It has potential to improve outcomes and reduce the risk of recurrence. The benefit of perioperative approach over neoadjuvant only ICI approach is yet to be confirmed, and the landscape for the perioperative ICI in the lung cancer is evolving rapidly with recently reported and soon to mature clinical trials. Thank you so much for your patient listening. Over to the organizers.
Hello, Dr. Manish.
Yes, Dr. Rajat.
Yeah, thank you for this very nice presentation. So, according to you, what should be the better approach, and are there any patients you would like to select for neoadjuvant only IO versus perioperative IO? And what have you, I mean, practiced till now, and any clinical outcomes that you would like to share?
So, I have not used durvalumab as a perioperative approach. I have used neoadjuvant nivolumab for 3 cycles in few of my patients, and I
Okay.
have got good responses. The PCR rates are high, but the overall survival is still, I don't know about that.
Okay. Okay. Yeah, because actually the approval also was on the basis of PCR only. The overall survival is still yet to come.
Yes,
And
yes.
what about the perioperative other immunotherapy trials? So, like perioperative Durva trial is actually a compelling data that you had shown. So you think that there is benefit of using perioperative in some subset of patients?
I think the data is really compelling, but the financial toxicity is also huge for these patients.
Okay.
So
Yeah.
as of now, the 3 cycles of nivolumab, I think they're sufficient. And
Hmm.
if the overall survival comes, then I think we will go with these trials.
Yeah, and also we do know that there is never going to be a trial which is going to compare both the two strategies. So, I mean, after all, it has to be the clinicians have to be into consideration.
Yes.
Also, we have seen with keynote 522 also that immunotherapy, if you give more of immunotherapy, especially in the post-operative setting, it can lead to IRAs, and we do not want IRAs in the adjuvant setting.
In the adjuvant setting,
So,
yes.
I mean,
At least
possibly,
I think at least those patients who have achieved PCR, these are the patients in whom I can skip giving perioperative, sorry, adjuvant treatment for 1 year. For those
yeah,
patients who have not achieved PCR, I think these would be the patient for whom I would prefer doing
yeah,
uh, full 1 year of perioperative treatment.
right, right, yeah. Thank you so much for your presentation. Thank you.
Thank you.
So now for the next talk, which is on the first-line management of ALK rearranged NSCLC. We have with us Dr. Ankur Nandan Vashne, who is a consultant medical oncologist at Medanta Medicity, Gurugram. Dr. Ankur, uh, over to you.
Thank you, Dr. Rajat. And I'm unable to share my screen. Okay, now it's permitted.
Kindly share, sir.
Okay. So is my screen visible to all?
Yes, sir.
And are the slides moving?
Yes, sir.
Okay. So hi, good evening, everyone. And now we are going to discuss a new benchmark in the first line management of ALK positive non-small cell lung cancer. As we already know that this is a difficult to treat disease, we will discuss what's in the current guidelines and updates. So looking over the lung cancer incidence, definitely we still discuss the Globocon 2020 data, where it is still the fourth most common cancer diagnosed in India. and majority of patients, approximately 44%, present with in metastatic stage at the baseline. Approximately 47% of females present in metastatic stage at baseline. Now, why it is important to discuss is because in 2020 there was 72,000 cases reported, but what we expect in the coming years is a more than this. We expect that this is going to be around 1.5 times, and an increased incidence of cancer will be reported. So, coming to the incidence wise, definitely cancer is going to increase, and as this, the death rates are also going to increase. So we need a drug which can provide us a better results. Coming to the incidence of ALK mutation in all lung cancer cases, the most, especially in the small cell, especially in the non-small cell adenocarcinoma, is the EGFR, which is a common mutation which presents in 23% of patient population. And ALK is reported to be the second most common targetable action mutation. And various studies report the incidence from 2 to 12% of the incidence. So, what are the special feature? It is usually present in typically adenocarcinoma histology. Most of the patients are typically non-smokers or light former smokers. Patient population is a typically younger age, around 30-40 maximum. The sensitive and specific diagnostic techniques are available, and usually these mutations, like ALK mutation and EGFR, are mutually exclusive. So rare case reports of existing mutations are also present. And the most common translocation is EML4 ALK translocations. So with the discovery of this mutation, we have that there is a gene pattern, and this gene fusion there's an inversion type of gene rearrangement where chromosome is broken into two pieces, and then this is reinserted from chromosome 2 to chromosome 5, leading to the ALK4 EML4 gene translocation, and this was initially reported in 2007. So what are the unmet needs we are still getting in ALK positive patient? Definitely we know that these patients are typically younger, have a longer life productivity, and the specific feature of ALK is a high incidence of CNS mets. Approximately 20 to 40% of patients had baseline CNS mets, leading to the poor prognosis. And definitely, if we look at the first generation ALK inhibitors, second generation ALK inhibitors, then there are various resistance mechanisms. And first generation is like crizotinib, doesn't have a CNS penetrations, and definitely we require spatial control of brain mets, as well as preventing prevention of brain mets during treatment is also mandatory. So we see that ALK positive again in ALK positive, chances of brain mets are present in 20 to 30% of patient populations. All guidelines recommend routine use of MRI with contrast for evaluation of CNS mets at baseline. And there are several tyrosine kinase inhibitors are present, which has demonstrated prolonged PFS and intracranial efficacy. We will study these drugs now. So coming to the in oncogene addicted non-small cell lung cancer metastatic, definitely there is an increased incidence of development of brain mets, and these incidents further increase in presence of ALK inhibitors, ALK mutations. So why we have a thing that we have to choose between what should be our first line inhibitor? We depends mainly on the CNS activity. We need an overall survival data. We need an overall efficacy data, and definitely response rates and progression-free survival again. So we have a new drug which is called as lorlatinib, and this is a selective third generation ALK inhibitor which has an excellent brain penetration, addresses approximately 75% of the drug goes to the CNS, has shown improved clinical outcomes with increased intracranial activity in patients who have been previously treated as well as untreated ALK positive advanced NSCLC. And definitely we will discuss the data of upfront treatment in the coming slides. So we have this data, the CROWN study. So the CROWN trial, this is a phase 3 study, randomized, where patients who were having a stage 3B or 4 ALK positive NSCLC, prior treatment was not permitted. Patient has a preserved performance status of 0 to 2. Usually untreated CNS mets were permitted in this trial, and definitely these patients have more than one extracranial measurable target lesions. Now, these patients were randomized to either receive lorlatinib 100 mg OD and crizotinib 250 mg BD, which was the standard at that time when this trial was started. The primary endpoint of this trial was PFS, and secondary endpoint was overall response rate and OS safety and quality of life data. So we see the baseline characteristic. Definitely, the patient population was younger. Slightly female preponderance was noted. The significance to us of this study is approximately 44 patient population was Asian patient population. These usually have a preserved performance status, and majority of them were ECOG 0 or 1. Majority of these patients were never a smoker or previous smokers. Majority of the patients were stage 4. Histopathology, definitely it was adenocarcinoma, and previous anti-cancer drug was found in only 8 patients in lorlatinib arm. Brain mets were present in approximately 25% of patient population, and approximately 5 to 6% patient populations had prior radiotherapy to brain. So coming to the efficacy, what we found in case of the PFS, which was the primary endpoint, 12-month PFS rate with the use of lorlatinib was reported in 78% of patient population, while with the use of crizotinib, approximately 39% of patient populations achieved 12-month PFS rate. So we see just doubling of the PFS rates. And by investigator assessment, it was 80% in the lorlatinib arm, it was 35% in the crizotinib arm. So more than double PFS rate was noted. If we see the median PFS, it was 9.3 months in the crizotinib arm, and it was not reported at the end of 30 months in the lorlatinib arm. So definitely this is a very good data which suggests more than doubling of PFS rates. Now coming to the 5-year analysis of this, and at the end of 5 years, so this is a very good thing to assess, is still approximately 60% of patients are maintaining the disease controls. And if we see the median events, then definitely median PFS is still not reached at the end of 60 months, while with the crizotinib it was reported to be 9 months. So we see a hazard ratio of 0.19, seldomly reported in oncology field. Now we divide these patients on the basis of presence of brain mets and without brain mets. So in the patient who have presence of brain mets at the baseline in the crizotinib arm, the median PFS reported was 6 months, while in the lorlatinib arm, it is still not reported. And at the end of 5 years, approximately 53% of patients are retaining their responses. And in the patient whom brain mets were not there at the baseline, we had a median PFS benefit of 10.8 months with the crizotinib, and it's still not reported in the lorlatinib arm. And at the end of 60 months, approximately 60-30% of patient population is still maintaining the response rates. So we see the advantage is there in both the arms, in whom patients who have presence of brain mets at baseline and whom brain mets were not there. So now we will assess the difference of the PFS. We have already studied month-wise data. We go ahead and we see that this clear-cut advantage with the use of lorlatinib as compared to the crizotinib. Now there is a study, so this is not a proper cross-trial comparison, but if we see the data of alectinib, which was published in Alex trial, the median PFS when compared to the crizotinib arm, it was reported to be 34.8. And as a comparator arm in the crizotinib, it was 10.9. So the hazard ratio of this is 0.43, while the hazard ratio of the crown trial, where lorlatinib is getting compared, it is 0.19. So we see that though this is a cross-trial comparison, definitely lorlatinib is going to provide a more benefit in terms of the PFS. So coming to the data of intracranial progression, we see events reported in the lorlatinib arm for the intracranial progression was only 9, while in the crizotinib arm, it was 65. The hazard ratio of this is 0.06. Approximately 92% of the patients in the lorlatinib arm were free of intracranial mets at the end of 16 months. There was no intracranial progression reported after 36 months. So if we assess this data on the basis of presence of brain mets initially and later without brain mets, then definitely we can see that median PFS in the was reached by 7.2 months in the crizotinib arm. In lorlatinib arm, it was not recorded yet. Same was reported in patients without baseline brain mets, and definitely it shows that the lorlatinib significantly delays CNS progression in patients with existing brain mets, as well as delay the onset of CNS disease in patients who doesn't have baseline brain mets. So now we have a cross-trial comparison again between the Crown and Alex. And if we see the intracranial progression rates, then these were not reported in the Alex trial. However, in patients with brain mets, median PFS reported in the crizotinib in the Alex trial was 2.1 months, while it was 40.5 months. In the crizotinib arm, and if we see the round trial data, it is reported to be 72.8 months. So definitely, lorlatinib is going to have a significant intracranial activity, which is more superior than the existing tyrosine kinase inhibitors. So if we assess this data again further, we see that confirmed overall response rate on the lorlatinib arm was 92% in the Crown trial, while complete intracranial response was reported only in 38% of the patient population in the Alex trial. So we see that lorlatinib resulted in higher intracranial responses, and majority of these responses are complete and durable. Coming to the subgroup analysis, if we study these with the help of variants, and there are certain variants of EML4 LK variant which are known to have a poor prognosis, then median PFS in the poor prognostic groups, which is V3, was 60 months in the lorlatinib arm, and it demonstrated thus that lorlatinib is quite effective in poor prognostic resistance pathway. However, the PFS which was reported in the Alex trial in this similar cohort was only 17 months. If we see the patient population in whom TP53 mutation status was reported at the baseline, then median PFS, which was reported in this patient population cohort, was 51.6 months. Thus, this shows that lorlatinib is quite effective in overcoming the resistant pathways and show a good clinical efficacy data in difficult to treat patient population. Now coming to the data of lorlatinib, which was recently reported in 2021 as first-line treatment, and we see that if this is compared with the other drugs, then definitely lorlatinib has a better efficacy rate and is going to be an effective first-line treatment for ALK positive NSCLC when compared to the crizotinib and other tyrosine kinase inhibitors. If they are immature, there was if we see the OS data, then definitely there is the OS data was immature for many of these studies, and we cannot draw a conclusion. But definitely, in majority of these studies, lorlatinib is going to have a better overall survival data as compared to the brigatinib, ceritinib, crizotinib, and azacitidine and chemotherapy. Now, this is a review article which has compared the various trials where lorlatinib, alectinib, and brigatinib was studied in ALK positive patient, and we see in terms of PFS, the result indicated that lorlatinib was the best treatment choice for patient with ALK inhibitor or which who are treatment naive, ALK positive advanced NSCLC, and definitely further direct comparison clinical trial, phase 3 clinical trial can draw much better results. So we see that lorlatinib has shown a significant PFS advantage in various systemic meta-analysis over alectinib and brigatinib. Coming to the subgroup analysis of this review, and we see the benefit of lorlatinib over alectinib is profound in majority of these subgroups where lorlatinib is getting preferred. And now, if we study the ranking of different TKIs, then definitely we see that lorlatinib is getting an upfront result in bringing the patients of CNS Mets disease. So what this network meta-analysis conclude definitely, as we have discussed, that lorlatinib was the best treatment choice if PFS is being considered among the first generation, second generation, third generation all TKIs. Lorlatinib had the highest probability to reach the best overall confirmed response rate an intracranial confirmed response rate. It has shown a significant PFS in cross-trial comparisons as compared to the other drugs, and OS data is still immature, but definitely getting much better results the use of lorlatinib. So coming to the resistance patterns which can emerge after the use of TKIs, and we see that these are the resistance pathways where with the upfront use of other TKIs, we see that there are certain mutations which derive resistance to the alt drugs and the patient shows disease progression. Out of this, the most important significant is G1202R mutations, which is quite prominent with the use of ceritinib and alectinib resistant pathways. Now we have this specific data that this G120R mutation is sensitive to the lorlatinib, and lorlatinib works specifically in all these resistance pathways, and all the resistance path and compared to the other drugs, definitely the lorlatinib is exhibiting a broad spectrum activity against all these resistance, working well, and this eruption of these resistance is also delayed with the use of lorlatinib when used as a first line drug. So we can see in these charts that more generation of TKIs were sequenced, more disaster resistance mutations appeared. But with the use of lorlatinib, the onset of these delayed resistance mechanism is significantly delayed. So this provide the upfront for the use of lorlatinib, which suppresses the emergence of ALK resistance mechanism, and definitely upfront use of lorlatinib could significantly delay and suppress these resistance pathways. So this is the trial design again, and we see approximately 32 patients who were previously treated with chemotherapy and crizotinib. Approximately 28 patients have second generation LTKI with or without chemotherapy. And definitely these are the resistance mechanism. With the use of lorlatinib, we have a significant PFS benefit in these resistance pathways. And if we analyze the resistance mechanisms to first line lorlatinib, definitely no new ALK mutations or resistant pathways were developed in this lorlatinib cohort in the patients in the Crown study. So the most important facts that we study with the drug is the safety analysis. And definitely, if we see, then in the crizotinib arm, adverse events leading to permanent discontinuation drugs were reported in 11% of patient population, and the same was reported in the lorlatinib. If we see the adverse event leading to permanent treatment discontinuation, they were reported in 6% of patient population in the crizotinib arm. They were reported in 5% of patient population in lorlatinib arm. So the incidence of any grade adverse event is a bit higher, but that's are marginally higher. But if we see the treatment discontinuation because of the drug and adverse event, then these are quite comparable and largely manageable with concomitant therapies. Requiring the interruptions are quite temporary and can be managed well with the use of dose reductions. If we see the frequency of dose reduction, definitely in the crizotinib arm, there was reported in 15% of in the Crown trial. It was reported in 23% of patient population in the lorlatinib arm. If we see the LX data, definitely in the alectinib arm, 20% of patient population requires dose reduction because of adverse event. If we see the data of discontinuation due to adverse event, in lorlatinib arm, it was 11% reported. In alectinib arm, it was 14% reported. So we see the important side effect of interest with the use of lorlatinib includes the hypercholesteremia, hypertriglyceridemia, peripheral edema, slight more incidence of peripheral neuropathy. But majority of these adverse events are quite grade 1 and 2 and seldomly requires grade 3 and 4 are less reported. And the adverse event of interest were definitely increased deranged lipid profiles, which we all know. And these can be managed with the use of concomitant statins. The important side effects which requires further dose reduction is the cognitive effects and mood effects. So summary of CNS adverse events and comparing to with the use of lorlatinib, we see the cognitive effects, mood effects, speech effect, and psychotic effects. Majority of these are in grade 1 and 2 only, and randomly grade 4 adverse events were reported in psychotic effects were reported in only 1% of patient populations. So majority of CNS side effects with the use of lorlatinib are grade 1 and grade 2, and majority of them are treated with the reduction of dose. So if we study the adverse event of clinical interest, then very first is the hyperlipidemia. Approximately 72% of patients have reported the increased incidence of hypercholesteremia, and 66% reported hypertriglyceridemia. Approximately only 1% of patient population had led because of hyperlipidemia led to treatment discontinuation. If we compare the incidence of hypercholesteremia to the cardiovascular event, then this was quite lower than the crizotinib. It was only 28% patient where cardiovascular dysfunction was reported because of the hyperlipidemia. If we see the CNS adverse event, then definitely these are experienced with the 42% of patient population, but only 2% of patient population required discontinued treatment because of these, and 3 patients who experienced treatment-related CNS events permanently discontinued lorlatinib. Edema and weight gain definitely was present in approximately 57% of patient populations, but no patient discontinued the drug because of these adverse events, and 7% of patient who experienced edema and 1% of patient who experienced increased weight gain required dose reduction. So we see that adverse events of clinical interest are quite grade 1 and 2 and quite manageable, especially with the dose reduction.
Ankush sir, sorry for interrupt you. Kindly conclude your talk.
Okay, so we see that there we have a 5 year survival data, and no new safety signals have been there. And as there is a time lag, we move ahead to the fact that if we require dose reduction, also we see this therapeutic advantage is maintained in reduced cohort also. So now concluding my session, after 5 years of follow-up, median PFS has not reached in the lorlatinib arm, and corresponding to the fact that this drug is going to provide the longest PFS reported in treatment of NSCLC, which is molecular target or positive, and it is a drug which has shown intracranial progression over and as compared to the various other TKIs, this has shown significant CNS activity. It is quite effective in controlling the pre-existing brain mets as well as protect against the development of new brain mets. Regarding safety, definitely there is increased incidence of side effects, especially the hyperlipidemia and CNS side effects, but these are quite manageable with the dose reduction, and definitely low number of patient population requires treatment interruption or change in treatment because of these things. So we can have the CNS systemic efficacy along with prolonged intracranial efficacy and quite safety in a drug with the use of this drug. So, and with this, definitely we are having that lorlatinib is category 1 recommendation in NCCN, and it may move further higher with the coming of overall survival data. Thank you.
So thank you so much, Dr. Ankush sir. So is there any question? Okay, so moving ahead the next session, and this session is sponsored by Roche. And I would like to invite Dr. Rajat Bajaj to give his talk about optimizing treatment strategy in management of 1L MNC MNSCLC. So it's over to you, sir.
Yeah, thank you. Can I have the slides, please? Gitika, can somebody up? Yeah. So, good evening. I'm going to talk about the role of Tecentriq in first line management of metastatic NSCLC. Tecentriq is atezolizumab, as all of us are aware, and we're going to talk about 3 trials: IMPAR 110, 130, and 150. So, next slide. We know that a non-small cell lung cancer is a common disease which affects mostly the male population in our country, and it is a common disease that we practice in our OPDs. There can be a variety of NSCLC, which can be a slow growing tumor, or it could be rapidly growing as well. Although compared to small cell, they are slower growing. They're about 80 to 85% of all the lung malignancies. Small cell constitute about 15%, and metastasis does happen in most of the cases, especially when the patient comes to us. We have a lot of targeted agents that have come up in the last decade or so, which have improved the survivals, as Dr. Ankur was also talking about the ALK inhibitors in NSCLC. Next slide. But then the fact of the matter also remains that not all patients would be mutation positive, be it EGFR, ALK, ROS, or BRAF, or for that matter, CMET and other smaller subtypes. And there have to be certain subtypes which would be known as wild type of NSCLC, where no mutation comes out to be positive. This particular slide tells us that the evolving landscape of lung cancer treatment from the 1980s to 2020s now has included in the treatment paradigm chemotherapy. Along with that, after a certain point, was chemotherapy plus anti-angiogenic inhibitor, especially for adenocarcinoma. Then came the advent of targeted therapy, and now the era is of immunotherapy, which is checkpoint inhibitors. Next slide. If we talk about the unmet need in the treatment of patients of NSCLC, especially for non-actionable mutations, like I said, that these patients also are a large chunk. Here in the figure, it is supposed to be somewhere around 25 to 30%. It is seen that patients who have got a targeted therapy, they have got doubling of overall survival. But if there is no targeted therapy, the overall survival dips very sharply. But probably with the use of immunotherapy, the overall survival can come up. It may not reach up to what it is for targeted therapies, but certainly can improve. Next slide. If you look at three global phase 3 studies of atezolizumab in first line, one is 110 IMpower, which is atezolizumab monotherapy pitched against the standard of care of chemotherapy, IMpower 130 and IMpower 150. Next slide. Talking about IMpower 110, which was a histology agnostic study, which was both in squamous and non-squamous. Atezolizumab monotherapy, which was compared against a platinum-based doublet of either a cisplatin or carboplatin plus a pemetrexed or a gemcitabine, depending on the histology in first line NSCLC. Next slide. This is the trial schema of that particular study. One can see that these patients were chemotherapy naive, and they were EGFR and ALK had to be negative. With a PDL1 expression being the stratification factor, they were randomized 1:1 to either an atezo monotherapy or a non-squamous or a squamous based histology specific chemotherapy, which was platinum based, as we have discussed. The primary endpoint was kept as overall survival in the wild type population, and PFS and overall response rates were the secondary endpoints. Next slide. Now, they looked at all comers for sure, but they stratified based on PDL1 expression, like I said, and they found out that the prevalence of PDL1 expression was about 1/3 of the patients having a high PDL1 expression, which was a TC3 or a IC3. Now, since these patients are all wild type, one can see the WT written over there. TC3 meant more than equal to 50% of TC, that is tumor cells, and IC3 meant more than equal to 10% of the immune cells in the tumor microenvironment. The assays which were done for PDL1 were mostly SP142 assays, which were followed because of it being a companion diagnostics, US FDA approved for Tecentriq. Next slide. If we talk about the baseline characteristics, one can see that the baseline characteristics uh, they were matched between the low and the high PDL1 expression. There were mostly patients who were males, mostly patients who were never tobacco users, and mostly patients who were non-squamous histology. Mostly patients were good performance status.
Sir, your voice is not audible, sir.
Yeah, is
Can you
it better now?
unmute yourself?
Yeah.
Yes.
So, yeah. The next slide, please. The primary endpoint of overall survival in the high PD-L1 expression subgroup was met, and one can see that the median OS improved by 7 months for atezolizumab monotherapy versus chemotherapy, OS of 20 months versus 13 months, and the p-value was significant, which was 0.01 with a hazard ratio of 0.59. Next slide. IMPAR 110 also showed to the forest plot that the OS in the key subgroups were also met with the non-squamous histology, be a never patients who were be it the history of smoking there or not there, or patients who were PS of 0 or 1. Almost all patients benefited, and one can see that the diamond was on the side of the experimental arm, with the overall diamond also being at hazard of 0.59 as we discussed. Next slide.
Sir, can you please open your camera?
Yeah,
Yeah, sure.
next slide, please. Now, after a longer follow-up, also one could see that the continued OS improvement was observed in the atezolizumab arm versus chemotherapy arm. In the updated exploratory OS analysis, the higher PD-L1 expression of the wild-type population continued the OS improvement of atezolizumab monotherapy versus chemotherapy arm, and the hazard ratio being 0.76, and this is a median follow-up of 31.3 months. Next slide. If you look at the subsequent therapies, the subsequent therapies also, there were about 35% of the patients in the control arm who received subsequent chemoimmunotherapy, and despite that, the overall survival difference was seen, which is that tells us that the results of this trial was significant. Next slide. Now, if you see the OS hazard ratio, it more strongly favored atezolizumab versus chemotherapy after adjusting for the subsequent immunotherapy which was used. Now, if we talk about the subsequent immunotherapy which was used and the adjustments, as one can see then the Kaplan-Meier curves, they are separating robust with a hazard ratio of 0.69, and this tells us again about the robustness of the data that this particular trial generated. Next slide. Also, we do know that PDL1 can be calculated by either an SP263 or a 22C3 or a SP142. SP142 was the most common PDL1 clone which was used in this particular trial. But if you look at the OS benefit in PDL1 high subgroup population for patients who were calculated for PDL1 high expression by other clones like 22C3 or SP263, there as well one can see that the quantum of benefit of atezo mono versus chemo was maintained, be it patients of 22C3 or SP263, which means that the PDL1 biomarker or a clone specific PDL1 is not really a deterrent for an atezo monotherapy. Next slide. If you look at the PFS also was improved. It was about 8 months versus 5 months with a hazard ratio of 0.6963. Next slide. And an updated analysis also showed that there was a clinically meaningful improvement in PFS. Next slide. ORR, that is overall response rates, also 40% versus 28%. This also was improved for atezo monotherapy in the high PD-L1 expression. Next slide. Updated safety profile told us that these patients of atezo monotherapy did go on to have IRAEs, which was expected, but then most of them, they were grade 1 and 2, and there were very few grade 3 and 4 IRAEs, and the IRAs which led to a treatment withdrawal or discontinuation were less than 10%. So it was a fairly well tolerated therapy that
Meeting
atezo
चल रही है
monotherapy
मेरी.
was. Next slide, please. Now, all cause AEs also, there was a higher the hematological toxicity with chemotherapy, be it anemia or neutropenia, thrombocytopenia, which was less with the immuno arm, but there was more of transaminitis one can see and more of hypothyroidism, which is again an IRA. Next slide. So to summarize, this was a trial which was a pivotal study to define the atezo monotherapy as the standard therapy for patients who were having a high PD-L1 expression, be it from SP142 or 22C3 or 263. And these patients demonstrated a statistically significant and clinically meaningful improvement in overall survival with a good hazard ratio of 0.59. The safety profile was consistent and it was manageable, and the favorable safety profile did compel us to use atezo monotherapy in high PD-L1 expression subgroup patients. Next slide. Now talking about IMPAR 150, which was a study which was used only in non-squamous NSCLC patients. Non-squamous NSCLC patients had this study where atezolizumab plus chemotherapy and bevacizumab in first line was used. Next slide. This is the trial schema where 150 patients, they were randomized to receive in patients who were non-squamous, like I said, stage 4 patients, 1:1 to receive 1:1:1. That is, 3 arms were there. The third arm was the comparator arm, which was paclitaxel carboplatin plus bevacizumab with bevacizumab maintenance, and the experimental arms were atezolizumab plus paclitaxel plus carboplatin followed by atezo maintenance, or there was another arm of ABCP, which was atezo plus bev plus pacli plus carboplatin with atezo plus bev maintenance. And this was on the basis of the stratification factors of gender, PDL1, IHC, and liver metastasis. And one can see that the clinical questions that they had in mind was, that is, whether the addition of atezolizumab to the standard of care of bev plus pacli plus carbo does add anything to the clinical benefit, and is there any improved clinical benefit if bevacizumab is replaced by atezolizumab. The co-primary endpoints were PFS in the intention to treat population and the T effector high wild type population. Next slide. Along with the overall survival. So we are all aware that atezolizumab and bevacizumab have got synergistic action, where bevacizumab decreases the activity of the T regulatory cells and enables the reprogramming of the tumor microenvironment. And thus, in effect, what it leads to is atezolizumab's ability to restore the anti-cancer immunity through the T cell mediated cancer cell killing. Next slide. Now, all this does make a difference in the TME, and how does it really translate into clinical benefit? We'll see that in a while. Baseline characteristics, they were well matched between arm A, B, and C, and one can see that there were a good number of patients who were poor prognostic patients. About 15% of the patients had liver metastasis in all the arms. EGFR mutations were, say, about 10% in all the arms, and there was an approximate 50%, 50 is to 50 split between PDL1 positive and negative patients. Next slide. So there was a significant OS benefit with the addition of atezolizumab in the intention to treat wild type population, arm B versus arm C. So arm B versus arm C was the main objective of this study, that is bevacizumab plus paclicar versus atezo plus bev plus paclicar. And one can see that the median PFS was median OS was increased 20 months versus 14 months, with the hazard ratio of 0.8, with the p-value being significant, and the Kaplan-Meier curves which are separating from the very beginning. Next slide. Next slide, please. And not only that, the overall response rates and the duration of response were also improved in the intention to treat population. About 70% was what was reached as the overall response rates in the ABCP regimen in the PDL1 high subgroups. Even in the PDL1 intention to treat population, it was about 56%. Next slide. The PDL1 high patients derived the most benefit, and one can see that the ABCP versus BCP regimen, if we see the hazard ratio of 0.7 and at the Kaplan-Meier curve which was separating, OS benefit was observed across the PDL1 subgroups. Next slide. OS benefit was observed irrespective of OS benefit was observed irrespective of PDL1 status. And also, next slide, if we see the poor prognostic factors, patients where the EGFR was positive or liver metastasis, these patients also did improve. So if we talk about the EGFR positive patients, next slide, one can see that these patients were there in this particular subgroup. In about 15% of the patients, EGFR was positive, and initially they were given EGFR inhibitors. Next slide. And here also there was almost a doubling of PFS. Sorry, here also there was about a 2.2 months improvement in PFS from 9.7 months, between 9.7 months and 6.1 months, with a hazard ratio of 0.59. Next slide. And OS benefit in patients with sensitizing EGFR mutations was seen between arm B versus arm C as the most important, which has that ratio of 0.6. But A and C, they were almost the same. So no benefit was seen in patients who were given bevacizumab plus paclitaxel versus an atezo plus paclitaxel. So the important thing to understand is that the ABCP regimen was the one which was actually making the whole of improvement. That is again a synergistic action between atezo and bevacizumab. Next slide, please. OS benefit in patients with sensitizing EGFR mutations prior to TKI therapy. With prior TKI therapy, like I said, that there was a continued clear separation of curves, and the OS benefit was seen with ABCP regimen. Next slide. The overall response rates are also higher and reaching up to 70%, which was an impressive figure to reach. Next slide. If you look at the liver metastasis, these patients again are proverbially bad prognostic patients. Next slide. And here also PFS was observed to be improved from between arm B and arm C. Next slide. And OS benefit was also observed in patients with liver metastasis when bevacizumab was added to atezolizumab. Next slide, please. Response rates again in the excess of 60% were impressive, vis-a-vis 40% for chemotherapy. Next slide. Talking about the bulky subgroups. Next slide. Here also, between the high disease burden and low disease burden, one can see that if you look at, next slide, if you look at the Kaplan-Meier curves, patients with higher disease burden, they did better with atezo plus bev plus paclitaxel combination versus patients who were not given atezolizumab. So addition of atezolizumab did make a lot of difference even in these sort of patients. Next slide. And they were adequately represented in this particular trial. Next slide, please. Next slide, please. So the summary is that this is a trial which has met its co-primary endpoints, both OS and PFS, in patients who are non-squamous histology. And especially for patients who are EGFR mutant and liver metastasis, this is a good combination to give, where the safety profile also is similar to what is seen with patients where immuno plus chemotherapy is given without any VEGF inhibitor. Next slide. Now talking about IMPAR 130, which is for the non-squamous histology, patients with nab-paclitaxel plus carboplatin were given atezolizumab plus minus in the experimental and the control arm for first-line NSCLC patients. Next slide, please. We have already known the rationale for combining atezolizumab and chemotherapy. Next slide. This is the trial design where we see that the use of nab-paclitaxel has been done so that the steroid sparing effect can be seen, and pemetrexed was used as the maintenance therapy in the experimental arm, whereas in the control arm, whereas in the experimental arm, atezolizumab maintenance was given. Next slide. And this is purely for non-squamous patients, and it was all comers without any PDL1 stratification. Next slide. One can see that the co-primary endpoints for OS and PFS, again, the baseline characteristics, they are matched, and there were about 25% patients in both the arms which were bone metastatic. There were about 15% patients who were having no history of tobacco use. So fairly well planned study. Next slide. If you look at the PFS, it is improved, that significantly improved with a hazard ratio of 0.64. Next slide. And even the overall survival was improved. One can see that the OS was 18.6 months versus 13 months. Next slide. And the baseline characteristics were also matched with the OS benefit. Next slide. Between all the subgroups, be it liver metastasis present or not. But in EGFR positive population, the benefit was not seen. So ABCP regimen can be a regimen for EGFR positive, but not atezo plus chemotherapy. Next slide. The quantum of benefit was certainly more if there was a high PD-L1 expression, but it was there in almost all, and a higher proportion of patients had a complete or partial response in the atezo arm. One can see the according to the best response also, it was more for the experimental arm versus control arm. Next slide. This regimen was well tolerated with a safety profile which is consistent with the known previous published studies. Next slide. So the conclusion was that it was a positive phase 3 study. There were patients where this regimen helped in improving the OS and the PFS both, and it is consistent with the safety profiles are also consistent with what is known for the chemoimmunotherapy combination, and this is a regimen which is approved by MCCL. Next slide. With this, I thank you for your patient listening. Geetika, back to you.
So thank you so much, Rajat Pajas. Also for the next session, and I would like to invite Dr. Arpit Jain, sir. He's a consultant Department of Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi, and to give his talk about role of PARP beyond BRCA. And this session is sponsored by Zydus. It's over to you, sir.
Yeah, good evening. I hope my voice is audible
Yes,
and my
sir.
slides is visible. Yeah, good evening. Thank you to the
Sir,
organizers.
kindly upload your slides, sir.
Okay. I think it is in the presenter mode itself.
So tech support, can you please help out? Can you please check again, sir?
Sorry.
सर स्लाइड अप नहीं कर पा रहे हैं, एक बार आप चेक करेंगे.
आप एक बार शेयर स्क्रीन पे क्लिक कीजिए.
Okay.
हाँ, okay.
I think now it is visible.
Yes, make it full screen.
Yeah. So good evening. So my job is to present the role of the PARP inhibitors beyond the BRCA,
Sir,
particularly
your
the
slide is not in full screen mode. Can you please click on play button on the top?
Now it is okay, I think.
No. Can I run from my side?
Yeah, sure. Yeah. So to begin with the basics of the PARP inhibitors. So basically it works on the synthetic lethality, very basic. So in normal cell, if both the HRD pathways, homologous recombination pathway is intact, the cell undergoes the survival mechanism. Even if there is any single strand break or the double strand break occurs. If there is a HR pathway defect, then in particularly if any single strand break occurs, subsequently in the replication process, it turns it into the double stranded break. And in the absence of the HR pathway and the presence of the PARP inhibitor, ultimately the cancer do not survives its mechanism and ultimately goes to the cell death. Next. Next. Yeah. So this is again a repetition of the similar mechanism. Basically, it works on the synthetic lethality, where the presence of one defect in the presence of the other drug or particular mechanisms, both the mechanisms finally lead to the cell death. Next. Then comes the various panel or panels to test the HRD particularly. So HRD is a manifestation of any defect in the homologous recombination pathway, including the various HRR genes defect, including BRCA1, 2, PALV2, and so on, including RAD51CD, ATM, CHEK1, and so on. So ultimately, the manifestation is the defect or the genomic scar in the DNA double strand, which can be detected by various panels, including Myriad's MyChoice, which is a FDA-approved validated panel, and the Foundation one, and the other laboratory certified or laboratory validated tests are also there at the particular institutes also. Next. Next, so HRD includes BRCA mutation, could be germline, including germline and somatic. Next, along with next, the other next, including the BRCA promoter methylation and certain other unknown causes, which ultimately leads to a manifestations or phenotypic presentations, which is which commonly termed as concisely termed as the HRD, which can be tested by various platforms. Next, using the NGS. Next. So again, there could be a genotype. There is a genotypic presentation, and subsequently it can lead to the phenotypic presentation also. But the catch is there is, even if there is a genotypic defect, there could be a chance that phenotypic presentation could be found out to be low, or the genomic score could be low, even if there is a particular genomic defect also, and vice versa also. Next. So in terms of the high-grade serous ovarian carcinoma, around 50% of all comers have some kind of the HRD defect, which which is there in about 50% of the patients, in which 22% of the patient have germline plus somatic mutation, in which 13% of the patient have germline mutation. So around 28% of the patient have the non-BRCA mutated defect, which manifested as HRD. Next, which could be the defect in about 15 HRR genes, including the presentations, which could be the BRCA promoter methylation and all. So in today's era, the landscape of the PARP inhibitors is there in four major cancer subtypes, like breast, ovary, prostate, and pancreatic cancer. And so the testing platform is also recommended in the subsequent subsites, depending upon their validations and recommendations. Like in ovarian cancer patients, we can directly opt for the HRD pathway testing. In breast, the germline BRCA testing is recommended. In prostate, we can go with the germline or the somatic, or directly with the tumor HRR panel testing directly. In pancreatic cancer, we can go with the germline, or we can opt for the broad gene panel, which includes the BRCA and some HRR like PALB2 also. So in pancreatic, we can go with the broad gene panel NGS, and we can directly go with the germline BRCA1, 2 mutation testing also. Next. So come to this thing, the clinical trials directly. So the role of the PARP inhibitors banned the BRCA mutations in the ovarian cancer. Next comes from the next, particularly in the maintenance setting. So in 25% of the patients, they have BRCA mutations. Next, where the role of the olaparib maintenance after completion of the primary treatment, first line treatment. Then comes the role of the HRD, which next makes around 50% of the high-grade serous ovarian carcinomas, in which the role of the olaparib along with the BEV in maintenance setting came from the Paula 1 trial after completion of the first line treatment. Next comes the role of the rucaparib after the presentation of the Athena mono trial. So to summarize, in the first line maintenance setting, if it is BRCA mutated, HRD positive, after completion of the first line setting, if the disease is responding to the platinum agent, then in maintenance setting, we have the data from the Paula 1, Athena mono, and Icon 7, where we can use the bevacizumab alone in high risk situations like stage 4 AB and not CC0 disease. Next. Similarly, there is a data which is supporting the use of the PARP inhibitors, particularly the rucaparib, in HRD negative subsets also, which came from the data presented in the Athena mono trial. Next, which is endorsed in ESCO and NCCN 2024 also. So if we see the latest version of the NCCN, it incorporates the PARP inhibitors in the maintenance settings depending upon the BRCA status and the sensitivity of the disease to the platinum agents. So if we use prior bevacizumab along with the first line setting in this maintenance setting, if it is a HRD, then we can opt for the bevacizumab along with the olaparib as per the Paula 1 trial. If it is BRCA wild type alone, then we can opt for the niraparib or rucaparib. If it is germline BRCA1 or 2 mutated, after achieving a response, that is CR or PR, we can opt for the any one of the 3 PARP inhibitors, could be olaparib, niraparib, or rucaparib. Next. Next. So these are the trial schema of the 2 landmark trials. One is Solo 1, where all the patients with the with the PIGO stage 2, 3, and 4, high-grade serous or endometrioid ovarian or the primary peritoneal carcinoma with BRCA mutations was enrolled. 2:1 arm between olaparib and placebo, and this olaparib maintenance was continued for 2 years or till progression. Similarly, in Paula 1, all the patients, irrespective of the HRD status, was enrolled and randomized in 2:1 in the arm A, which was olaparib along with the BEV. BEV was continued for 15 months. Ola was continued for 2 years versus placebo plus BEV. Next. And they found out that, as is being depicted in this KM curve also, in Solo 1 trial, particularly in the BRCA mutated settings, which was the primary inclusion criteria of this study, they achieved a significant improvement in the median PFS to the tune of 56 versus 14 around. So there was an improvement of around 42 months with the use of the olaparib for 2 years in the maintenance setting in the BRCA mutated patients with a significant HR value of 0.33. Similarly, in the patients, and the results of the Paula 1, particularly in HRD positive patients, again reaches a significant value with a median PFS of 37 versus 17. Next. Similarly, Paula 1 again reaches its secondary endpoint, which was overall survival in both HRD positive patients and also in the BRCA mutated BRCA mutated patients also. And they excluded the BRCA mutation status from the HRD. So basically, the maximum response was there in BRCA mutated patients. Then the gain in the outcome was there in the HRD positive non-BRCA mutated patients. And both reaches a significant value with the significant improvement in the HR value to 0.60 in BRCA mutated and 0.71 in HRD positive, excluding the BRCA mutated patients. Although the curves are meeting in between, and then it started separating in the subsequent analysis also. Next. So the investigators concluded the results of the Paula-1 is as there is a significant improvement in the OS with the use of the OLA plus BEV, and it reaches by 5-year improvement in the OS rate to the tune of 65% versus 48%. Next. And this improvement was there irrespective of the BRCA mutation status. Next. Then comes the role of the PARP inhibitors in the recurrent setting, which came from the publications of these 4 trials. The role of the OLA came from study 19 and solo 2 trial. The niraparib with NOVA and rocaparib role came from the Ariel 3 study. In niraparib, in NOVA and the Ariel, all the patients with non-germline BRCA mutation was also enrolled, and they again reaches to the significant p-value in terms of the PFS, as was assessed by the investigator or and also shown in the blinded independent central review assessment also. Next. So there came the role of the PARP inhibitors, including the OLA, NIRA, and ROCA in the recurrent setting in the maintenance phase also, as is shown in these curves also. In study 19, there is improvement in the median PFS with the use of the olaparib till progression, or if any significant toxicities occurs on the treatment per se. Next. Then comes the clinical trial, which is ORIO, which shows if there is a role of re-challenging the olaparib. So this was the basic trial schema, where they enrolled all the patients with BRCA mutated versus non-BRCA mutated. And after a phase of around 1.5 years post first-line completion of the chemotherapy. Next. And the PFS benefit was shown in BRCA mutated cohort also and in non-BRCA mutated cohorts. And if we see the subgroup analysis in non-BRCA mutated cohorts, the PFS benefit sustains in all comers. So they have stratified these patients based on the prior bevacizumab use and so on. Multiple factors were there, and the benefit was there even in such patients also. Next. Next. So then they concluded with this chart that in platinum sensitive recurrence setting, there is the role of the PARP inhibitors, and there was previously some recommendations based on the HRD status in the platinum sensitive recurrence also. Now they have withdrawal because of the absence of the overall survival benefit, as was there in the real world clinical trials, as was not shown in the real world clinical trials like Solo 3 and Orpazo. So now only the recommendations is only favors the use of the PARP inhibitors in the BRCA 1 or 2 mutated patients only. Next. Next. And there is the role of the this PARP inhibitors challenge also after a significant amount of the disease-free survivals. And if the patients was not progressed on prior PARP inhibitors per se. Then comes the role of the PARP inhibitors in the prostate cancer setting. So we know that the HRR mutations is being found in around 25% of the patients with the metastatic CRPC. So around 8.7% in the BRCA2 is comprised around 8.7, as was there in the PROFOUND trial. Around 1% of the patients have BRCA1 mutations. Similarly, next. So the incidence of the BRCA2 is around 3.5 to 5.2% germline BRCA mutation in the prostate cancer patients, and the indications came from the trials, which is Profound and Triton 3. So we can use either olaparib monotherapy in metastatic CRPC post at least 1 or 2 lines of the therapies. It could be ARPIs or the taxanes, and we can directly use the olaparib along with the anti-androgens or ARPIs in the first line metastatic CRPC patients also. So the approved indications is like in the subsequent lines, we can use it in the BRCA1, 2. Apart from that, the other around 15 HRR genes are also there where we can use the olaparib monotherapy. Similarly, the indications is for BRCA1 and 2 for the combination therapy, which is olaparib along with the ARPI in the first line setting. And a trial which is Propel, it shows that the role is there in the ATM mutations also. Some gain is also shown in the ATM mutated metastatic CRPC also. Then comes whether there is any role of the circulating tumor DNAs in the metastatic prostate cancer. So this was a trial. It enrolled around 24% of the patients in the progressive metastatic prostate cancers. Next, and they they compared the findings from the Garden 360 versus a Vancouver panel. Next, and they concluded that there is a
Sir,
significant
kindly
concordance.
conclude your talk.
Pardon?
Kindly conclude your talk, sir.
Yeah. Next. So we can skip these 2-3 slides. Next. So these were the key trials, which is Profound and Triton 3. Based on the Profound, we can opt the olaparib monotherapy in the post 1 or 2 lines of the therapy in the metastatic CRPC patients. Rucaparib can, again, based on the Triton 3, rucaparib can be opted. Next. Next, this is the basic trial schema of the Profound trial. Next, where they stratified the patients in cohort A and B, and both the cohorts, particularly the cohort A, shows a significant improvement in the radiographic PFS with the use of the olaparib. Next, as compared to the control arm, which is AR therapy alone. Next. 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 Yeah, then comes the role of the PARP inhibitors combinations therapies, which came from the trials like Magnitude, Telazopro, and next, Propel. So this is a Magnitude trial where all the patients with the HR mutation positive or HRR mutation negative, they were enrolled in the trials, and they stratified based on the status into the niraparib versus the placebo arm. Next. And the next, and the benefit was shown in the both HRR mutation, although there was a numerical improvement was also shown in the SRR mutated negative patients also, but it again was not reached to the statistical significant value. Next. So I think Telazopro, then comes the Telazopro, where the Telezoparib and the enzalutamide was offered in the patients in the first line metastatic CRPC. Next. And the benefit was there, and it has a significant improvement as compared to the comparator arm, which could be a placebo plus which was the placebo plus enzalutamide. Next. And the benefit was again shown in the HRR mutated negative patients also, but it was not statistically significant. Next. So the guidelines basically recommended that in all the patients with BRCA mutated first line metastatic CRPC, we can go with the olaparib plus abiraterone or the niraparib plus abiraterone. If it is HRR mutated, we should go with the telezoparib plus enzalutamide. So with this, I would like to conclude my talk and hand it over to the organizers. Thank you.
Okay, thank you so much, sir. Okay, so for the next session, and this session is sponsored by Takeda. and I would like to invite Dr. Rajat Bajaj sir, and to give his talk about defining treatment landscape in Hodgkin's lymphoma with dynamics. And so it's over to you, sir.
Hello. Yeah. Am I audible? Can you share the slide?
Yes, your slide is visible,
Yeah.
sir.
Yes. Yes. Thank you. So, good evening, everyone. Once again, so we are going to speak about the use of brentuximab vedotin, which is an antibody drug conjugate, anti-CD30 antibody drug conjugate, which has been there for a lot of years now. But then the clinical data set had to be mature enough for us to be compelling enough to use it. And now we have that evidence, and we use that in many lymphomas, and Hodgkin's lymphoma is one of them. There are other CD30 positive ALCL lymphomas also as the approved indication. We will be talking about the Hodgkin's lymphoma in this particular trial, and the three settings of Hodgkin's lymphoma is what we'll be talking about. So my disclaimers are that the slides have been provided to me by Takeda, and I'm contacted by them to speak about this particular topic. Now, defining treatment landscape in Hodgkin's lymphoma in three settings, like I said: frontline setting, the relapsed refractory setting, and the post-consolidation, post-setting. Next slide. Frontline particular aspect. So we do know that Hodgkin's lymphoma patients like uh,
Sir, your voice is not audible.
to us. So is it better now? Now,
Yes, sir.
now there will be patients of Hodgkin's lymphoma which will be stage 3 and 4 to begin with, and that constitutes, say, about 30% of the whole Hodgkin's lymphoma gamut. These patients would most likely, if you look at the standard of care treatment till about, say, about 2 years back, was a multimodality treatment of chemotherapy being ABVD, which is used. And one does know that not all patients would respond to ABVD1, and even if they respond, there can be early failures or relapses. Now, there is data set to suggest that one third of the patients of stage 4 Hodgkin's lymphoma treated with frontline ABVD will not achieve a long-term remission, which is the most important goal in such patients. And they, as the stage increases, there is a poorer remission and survival rate which is there with ABVD regimens. These remission rates are very important. One has to take due notice of them if one has to talk about the survival of these patients. So probably there was an unmet need in these patients of advanced stage 3 and 4 Hodgkin's lymphoma, where probably something should have been done to improve on the existing ABVD standard of care treatment. And that is when the role of brentuximab vedotin came in. We all know that Hodgkin's lymphoma is a CD30 positive disease, and this was an anti-CD30 monoclonal antibody. And how it really changed the treatment of stage 3 and 4 lymphomas. We'll see that subsequently in the Echelon trial, which was the pivotal study of this particular molecule. Next slide, please.
Sir, your voice is not audible.
Next slide, please. Can I have the next slide, please? Yeah. So
सर आपका वॉइस ब्रेक हो रहा है, so your voice is not audible.
of ABVD, and we have the option of brentuximab vedotin also, which is given along with AVD, where the B of ABVD, that is bleomycin, is replaced with brentuximab vedotin in the dose of 1.2 milligram per kg. Next slide. Now, the Echelon trial that I was talking about is a study where this is the trial design which is there in front of us, that patients of stage 3 and 4 advanced Hodgkin's lymphoma, they were randomized to receive either the standard of care, which was ABVD of 6 cycles, that is 12 sessions, day 1 and day 15, Q28 days, or brentuximab vedotin plus AVD, and which meant that bleomycin was replaced by BV, and it was in the dose of 1.2 milligram per kg up to 12 cycles, and only if the patient did not have a progression or unacceptable toxicity. The primary endpoint of this study was a modified PFS, which meant that a modified PFS is defined as time to progression, death, or evidence of a less than complete response after completion of frontline therapy, as per the independent review facility, followed by subsequent therapy. So this was monitored by the investigators as well as the sponsor and endorsed by the regulatory bodies. That is how the trial design was in this particular trial that we're talking about. Next slide. These are the baseline characteristics. So important to note is that there were about 25% patients who had got a high IPS score. There were about 60% patients who had got a stage 4 Ann Arbor stage. There were about 60% patients who were less than 45 years of age. And the bone marrow involvement was there in about 20% patients. Next slide, please. So a 6-year follow-up was published of this particular trial in 2022 of an overall survival benefit in patients of stage 3 and 4 Hodgkin's lymphoma, where brentuximab vedotin was used. Next slide. And this NEJM publication told us that the overall survival benefit was maintained even at 6 years of brentuximab vedotin based therapy over the conventional ABVD, where one saw that there was a 41% reported difference in the risk of death at 6 years, which meant that the hazard ratio of 0.59 was there in the overall survival, and it was 94% of OS versus nearly 90% of OS with ABVD, and there were fewer deaths with the brentuximab vedotin combination compared to the ABVD combination. And one can see that the Kaplan-Meier curves, they have separated till the very end, even at the 6-year follow-up. Next slide. Next slide, please. And this is ratio of 0.68 meant that a 32% reported difference in the risk of disease progression or death was reported at 6 years follow-up. Now, the subsequent anti-cancer therapies, which can be many, which can be a high-dose chemo followed by a transplant, or it can be immunotherapies or radiation, they were all, one can see from this graph, that they were all less with the brentuximab vedotin arm compared to ABVD arm, which meant that patients were more in remission, and when anti-cancer therapy is less. And be it at 2 years or be it at 6 years, there were fewer patients who actually went on to need and receive these therapies. Next slide. And if you look at the second malignancies, here also it was a good news from the experimental arm coming up, that these patients had a lesser hematological malignancies or solid tumors. That is the second malignancies we're talking about from the brentuximab arm compared to the ABVD arm. Next slide. Now, the use of growth factors with ABVD plus AVD reduced the incidence of neutropenia and related complications. So, the primary growth factor prophylaxis is recommended for all such patients who are receiving the brentuximab vedotin plus AVD combination. We know that ABVD, we do not really use growth factors till the time they are important, needed, till the time patient has had a grade 2 or more neutropenia. But here it is used because we are thankfully not giving bleomycin as well. So no neutropenia associated deaths were also reported, patients who were receiving a primary prophylaxis of GCSF. Next slide. So this is a safe combination to use. A 7-year overall survival analysis was also presented in this year ASCO, and the Echelon 1 study of A plus ABD versus ABVD. Next slide. Next slide, please. And one can see that the benefit was maintained even in the 7th year. Both OS as well as PFS benefit was maintained. Next slide. Next slide, please. Now, the overall survival benefit across subgroups, be the subgroups which were stage 4 or age less than 40. These are the subgroups which are considered the poor prognostic factors, and here the benefit was maintained. Patients with baseline extranodal sites more than one also benefited, and the quantum of benefit was more. So if there is a poor prognostic factor, this particular regimen will help us even more. Next slide. So to summarize, this study has told us that overall survival was improved with the use of brentuximab vedotin. It is a positive study and the primary endpoint was maintained. Even at 7 years, the significant OS advantage was seen, and there was a 38% disease decrease in the risk of death with a manageable safety profile. Growth factor support is required as a primary prophylaxis, and the OS benefit always is an important benchmark for us as clinicians to adopt that therapy which was there in this particular trial. Next slide. Now, talking about the relapsed refractory setting, next slide, where we do know that these sort of patients also are encountered frequently who have relapsed after the use of ABVD in the first line. This is an SGN 350003 trial, which is an international single-arm multicentric phase 2 study of Etcetris, that is brentuximab, to determine the overall response rates in such heavily pre-treated population. And this is post-transplant patients with the key endpoints which were assessed by an independent review forum. And these patients had earlier lines of therapy, then they had a bone marrow transplant done, which was a failure, and then brentuximab was given. And the dose of this was 1.8 milligrams this time, and not 1.2, which was in the initial setting. And the subsequent scans were done to assess the response, and the primary endpoint was kept as overall response rates in this phase 2 study. Next slide. The co-primary endpoints was PFS and overall survival. So 75% of patients received, there was an overall response rate and they was achieved, and out of those 34% patients achieved a CR. One can see that this waterfall plot is telling us the story that this is such an improved result with the use of BV in this particular setting. 94% of the patients achieved some tumor reduction. Majority of the patients achieved a more than equal to 50% reduction in the tumor burden, as one can see from the Kaplan-Meier curves. Next slide. The median time to achieve the response also was not too much. It was just about 5.5 weeks for the response rate, and the CR was in about 12 weeks. So this is a heavily pretreated population, which is post-transplant status. So this is certainly a overwhelming result that is seen with this particular this particular molecule. Next slide. After a 5-year follow-up, also one can see that the median OS and PFS, they were 40 months was and 9.3 months respectively. So certainly a good drug to give to such patients where the treatment options otherwise were limited before this particular results came out. Next slide. Now, median time to objective response in the phase 2 study and in the phase 4 study also, if we see, here also was say about 6 weeks. So the time to response is an important consideration when the patients are being treated for an advanced and a bulky disease, especially after transplant. And here it was a manageable time to response. Next slide. So the real world studies also have shown that etcetris is a treatment option for RRHL, and a good uh, early time to response is there. There is a robust PFS and OS benefit or data is there, and response rates are also good. Next slide. Now talking last 2 minutes about the post-transplant consolidation setting. Next slide. We have the Ethera trial, which is patients who are having a relapsed. It's a phase 3 study to assess whether patients who were receiving brentuximab, they had an improved PFS in the unfavorable risk relapsed or primary refractory Hodgkin's lymphoma when given as early consolidation after transplant. So either the unfavorable risk patients or relapsed patients or a primary refractory Hodgkin's lymphoma. So these patients were subjected to a bone marrow transplant. The eligibility stratification criteria were either a refractory to frontline therapy, relapsed less than 12 months after frontline, or relapsed more than equal to 12 months after the extranodal involvement. Brentuximab in the dose was given as 1.8 milligram per kg. The number of patients were 330 odd patients, and 1:1 randomized to receive brentuximab vedotin in the required dose or a placebo, with the primary endpoint being PFS and the secondary endpoint being overall survival. Next slide. Now, since these are poor prognostic patients, as one has seen in the trial, there still is a benefit with a BV placebo, and this is a PFS benefit that one can see on the screen after 5 years. At 5 years, the BV continued to provide a sustained PFS benefit, and the benefit of BV was more in patients who had more than equal to 2 risk factors. The hazard ratio for more than equal to 2 was 0.42, and if it was a higher risk factor of more than equal to 3, then the hazard ratio was even better at 0.39. Next slide. The BV demonstrated a consistent benefit in the risk of relapse, reduction in the risk of relapse or progression despite major risk factors for disease progression, as like I have told you. And if we talk about the risk factors, they were the primary refractory state or relapse less than 12 months from the completion of frontline therapy, PR or stable disease as the best response to the recent salvage therapy, extranodal disease at the pre-transplant relapse, B symptoms at pre autologous transplant relapse, 2 or more previous salvage therapies. So if we look at these patients and the risk factors which were there, if we had more number of risk factors, the results were even better with the use of brentuximab. Next slide. We know that the most common treatment adverse events in the etcetris arm have been peripheral sensory neuropathy. Next slide. But good thing is that this peripheral sensory neuropathy has over a period of time improved. After 5-year follow-up, 90% of the patients of these neuropathy have reported resolution or improvement and that gives us a good confidence in this molecule. Next slide. These are the recommended doses from the different settings that the drug is used in, and it is 1.2 milligram per kg for the upfront use along with AVD, but in all the other indications it is 1.8, capped at 180 mg for 1.8 milligram per kg use, and 120 milligrams as the maximum dose for 1.2 milligram per kg use. Next slide. So the conclusion for Ethera is that post-transplant consolidation with brentuximab for a classical Hodgkin's lymphoma provides greater PFS than placebo. The PFS benefit was observed with brentuximab, which was maintained till the study closure over 10 years. PFS benefit was pronounced in patients with more than 2 or more than 3 risk factors. Patients receiving brentuximab consolidation therapy required fewer subsequent antineoplastic treatments, and about 50% of the patients in the placebo arm received brentuximab as subsequent therapy. And despite that, the benefit was maintained. With this, I thank you all for your patient listening, and Geetika, take over.
Thank you so much, Dr. Rajat. So, is there any question? Okay, so for move ahead for the next session, and I would like to invite Dr. Narendra Gruhal sir. He's a senior consultant Department of Hemato-Oncology and Bone Marrow Transplant, Rajiv Gandhi Cancer Institute, and he's talking about treat CML newer avenues. So it's over to you, sir.
Thank you very much.
Sir, good evening.
Good evening, bhai. I was just looking at the agenda, and I was looking at what is there from hematology, hemato-oncology, and there's a session dedicated to hematology. Thankful for that, and thank you all the organizers for giving me this opportunity. So I'm given 10 minutes. We'll try to finish the topic in 10 minutes. Hope you can hear me and slides are visible to you all. These are my disclaimers. Only few slides are borrowed from Novartis. Rest of the presentation is prepared by myself. CML is one of the greatest success story in medical field, and obsolete therapies were hydroxyurea busulfan. Past curative treatments is allotransplant, which is still in use in certain patients like refractory or advanced CML. Current therapies for CML in chronic or accelerated phases are tyrosine kinase inhibitors from first to third generation. And for refractory and advanced phases of CML, we have again second and third generation tyrosine kinase inhibitors, the STAMP inhibitor, the asciminib, and for last phase, we have chemotherapies and transplantation. And definitely, there are certain unmet needs for which we need discussion, and future avenues are there for such unmet needs. So to discuss about best frontline therapy, there is still a debate whether we should do imatinib or should opt for second generation TKI nowadays when we have these TKIs readily available. Outcome varies in various studies between imatinib and dasatinib or nilotinib. Some of the studies claim that second generation TKI are better, while others say that these are almost same. But I think most important thing is to attainment of early molecular remission at 3 and 6 months, which correlates better with long-term molecular remission as well as survival. So whichever TKI you use, 3 months and 6 months remission is most important. And the most important thing is to make your own policy. You can learn by using one drug in a better way, and also you can generate a lot of data. And there is some data, comparative data of all the TKIs, first and second generation TKIs, showing almost similar molecular remission rates at 1 year and 5 years. There is not much of difference, except nilotinib showing a little higher MMR rates at 5 years. but the toxicities are different. I mean, first generation TKI is having different toxicities, while nilotinib having mainly cardiovascular toxicities, dasatinib having pulmonary toxicities as well as some cardiac toxicities, bosutinib having diarrhea and transaminitis. So there are certain toxicities attached to every TKI. And here are a few cases: a 29-year male having a weight loss abdominal lump for 6 months, presented with TLC of 1,70,000, spleen was 4 centimeter, ELTS score was 1.2 because of smaller spleen size. And the question is which TKI? So low score, ELTS, which TKI? The same patient having a huge spleen, and because of the spleen size, the ELTS falls into high risk. So which TKI will you use? And following slides, I will try to give the answer. This is long-term data on imatinib, the overall survival data. Here you can see the chronic phase patients have more than 80% chances of survival beyond 8 years, while patients who are not responding to imatinib has got very little chances of survival in the lower curve. Here is some data of comparison between dasatinib, imatinib. You can see better early response rate, cytogenetic as well as molecular response rate with use of dasatinib. So there are certain studies which definitely say that dasatinib is better or nilotinib is better. So that way dasatinib is better in these studies. And similarly, another study from the same MD Anderson group shows better results with use of dasatinib as compared to imatinib in terms of major molecular remissions and deeper remissions, especially the deeper remissions. So that way, dasatinib is able to provide more deeper remissions to more number of patients. And this is the similar data, long-term results of frontline dasatinib in patients with chronic myeloid leukemia. You can see a very impressive long-term molecular response and survival rate. And here is a special population, elderly population, patients more than 70 years of age. We can use very lower doses of dasatinib, 20 milligrams in frontline settings. And here the early molecular remission rates were 73%. That's also very impressive. And at 12 months, the remission rates, molecular remission rates were 60% versus 46% in the decision trial where the higher doses of dasatinib were used. So even lower doses of dasatinib as low as 20 mg can be effective in achieving molecular remissions when used in frail and elderly population. The same group published intermittent dosing as well as twice or thrice weekly or 4 times a week administration of only 20 mg dasatinib and found it to be successful in elderly population. And we too in our clinical practice have some patients who do not tolerate normal routine standard doses, and we keep them at lower doses, even 20 mg, and they are doing good for many years. So we have to take into account the ELTS score. ELTS is very easy to calculate. You just take age, peripheral blood blasts, spleen below costal margin, and platelet counts. It doesn't even require a marrow report to calculate ELTS score. And also while choosing our TKI, we should take into account patient preference, patient's age, comorbidities. Certain comorbidities preclude use of certain TKIs. And if we are using imatinib, nilotinib, there is nothing much to think. Only the thing is that nilotinib is to be used on empty stomach twice a day dosing. Dasatinib, we can de-escalate doses in a patient who is responding better, and we can use even lower doses. Coming to the next point, TFR consideration, treatment-free remissions is very important nowadays. There are multiple TFR trials. The success ranges from 40 to 70%. Patients who are most eligible for TFR trial are who have at least completed 3 years of therapy and have been in sustained deep molecular remissions for at least 2 years with regular monitoring, and who are motivated to abide to intensive molecular monitoring for at least 2 years and thereafter for lifelong. And it has been seen that in case of a molecular relapse, if we quickly resume the same TKI, patient again goes into molecular remission mostly. And there are few methods. Few of the trials stopped TKI abruptly, while others stopped gradually. They have reduced the dose to 50% for another year, then stopped if patient maintains the remission. and there is certain differences in the early success rate, but overall at the end of 5 years, most of the trials shows TFR success of nearly 40%. And these are few TFR trials. DASA-free trial, here dasatinib was used, and then TFR was successful in 46% of patients at the end of 2 years. And a stop trial, nilotinib used in second line after imatinib failure, and then nilotinib was stopped after attaining a DMR, and 1 year TFR rate was 57.9 and 5 year TFR rate 42.9%. Last study was with any of the TKI out of 4 used, and 12 months TFR was 60%. Coming to the most important part of this talk is difficult to treat situations. Patients who have failed 2 lines of TKIs, what to do for them. So mostly we have already used imatinib or a second generation TKI. These patients may or may not have a mutation. If there is a mutation, it can guide us better. But if there's not a mutation, we can use another second generation TKI, which again fails in most patients. So we are left with ponatinib and asciminib nowadays, and there are certain key studies in such kind of patients. Bosutinib was tried in third line setting in beyond study, and here the results were that patients who were resistant or intolerant to previous TKI had 64.3% and 81.8% patients achieving MMR with bosutinib. So it was an impressive result, but the disturbing thing was that many of the patients were having GI side effects, which leads to discontinuation of the bosutinib. Then there are certain trials with ponatinib. So ponatinib is third generation TKI, which was used in PACE study. And here the median follow was 56 months, and progression-free survival at the end of 5 years was seen in nearly 50% of the patients with or without P315I mutation, and overall survival in 73% versus 66% of the patients. Another is OPTIC study for ponatinib. Here, 3 different doses of ponatinib were used in randomized fashion, and we can see the MMR achievement, which was higher with lower doses of ponatinib 15 mg, while the cytogenetic response was better with higher doses. Here, the one important notable thing was that patients with T315I mutations required higher doses of ponatinib to achieve a molecular remission. And coming to the asciminib, which is a very latest and drug of very much interest. Here is the BCR ABL structure having ATP binding site where most of the TKI exert their action, and another site is myristoyl pocket, which is the target for this new drug asciminib. So basically, it doesn't compete with ATP for inhibiting BCR ABL. And there is a lot of data generated now. This is phase 3 ASSEMBLE study in relapse and refractory patients of CML. This shows impressive result when it was compared with bosutinib 500 mg once a daily as compared to asciminib 40 mg twice a daily in patients who have failed 2 or more TKIs, and T315I patients were excluded from this study. At the end of week 96, the 37.6% of the patients were in MMR as compared to 15.8% in bosutinib arm. Similarly, cytogenetic remissions were also 45% with asciminib in this difficult to treat population, and deeper remissions were also better with asciminib. So adverse events was mostly tolerated drugs, not many adverse events causing discontinuation. Thrombocytopenia was one of the important adverse event. Neutropenia was seen in few patients. And this is something about adverse events. So I'm in interest of time, I'm skipping few of the slides. Coming to case 2, is a real case, 20-year-old female. She had CML since the age of 10 years. Imatinib failed, came to us on nilotinib with high TLC. So she was already taking nilotinib and still having high TLC. IRMA was done, a mutation was found which was sensitive to dasatinib. So dasatinib was started, which could achieve a hematologic remission, but again, molecular response was not seen at 12 months. Repeat IRMA showed a T315I mutation. Ponatinib started. Again, she maintained hematological remission with intermittent cytopenias, required ponatinib dose reductions, but there was no molecular remission. So this patient we considered for asciminib addition over ponatinib. So ponatinib was continued in lower doses and asciminib 200 mg twice a day was added. After 18 months on combination therapy, patient is still not achieved a cytogenetic response. No HLA, mass donor, no option of transplant available. So we are just hoping for her to get into deeper responses. Lastly, allotransplant still curative for most patients who do not respond to TKI or asciminib. The current indications are patients not achieving complete cytogenetic response with any of the TKI, including ponatinib, or a blast phase CML after achieving a morphologic remission. Normally, myeloablative conditioning is what is recommended for younger patients. For older patients, we can use reduced intensity conditioning, and the survival is in the range of 70% for CML chronic phase, 40 to 50% for accelerated phase patients. And for blast phase, it's around 20 to 50% in various studies, depending upon the what kind of blast crisis is there, myeloid versus lymphoid. So to summarize, we need to choose upfront therapy very wisely, consider second generation TKI in selected patients. Dasatinib and nilotinib are better in providing early molecular remissions and deeper remissions earlier, and better chances of they can offer a better chances of treatment-free remissions later on. We should consider dose reductions and TFR in appropriate settings only. Not all patients are eligible. Whether the patient has achieved a deeper molecular remission, if patient is not able to do molecular monitoring very intensively, then probably that patient is not a candidate for TFR. Then we should use asciminib at least after two-line failure of. For now, we are yet to see a long-term data and real-world experience with this drug, and allotransplant in selected patients with refractory CML or blast phase CML. Thank you very much. I am ready to take any questions.
Sir, thank you for this very nice compilation of the treatment options that we have for CML. Sir, a couple of questions. In your practice, the first line therapy, are you going for first generation or second or third generation more? Just your personal choice.
Yeah.
And the other is your experience with TFR.
So again, both of the questions are, they are practical issues. We decided to use as a policy to use second generation TKI. And when this nilotinib was available through a PAP, we prefer to use nilotinib. Nowadays, we are having dasatinib, which is cheaper as well as not that toxic. So we as a policy use dasatinib in each and every patient, whether it's a low risk or a high risk ILTS or SOCAL. And we are now actually doing a trial on as well. This is an observational study of dose reduction. So we are starting with 100 mg, and those patients who are achieving a good EMR of less than 1%, BCR-ABL level at 3 or 6 months, we reduce the dose to 50 milligrams and then observe. So that way we are. And for TFR, we are using this dose reduction strategy. For 1 year, we reduce the dose to half, and then later on we stop the TKI in patients who are responding and who are abiding to the intensive monitoring. So that way, we found it very useful, successful in our patients. We are yet to generate, analyze the data, and later on probably will come out with some hard data of from real world.
Okay. Right, sir. Thank you so much.
Thank you very much for patient listening.
Thank you.
Thank you,
Thank you,
organizers.
sir. Thank you so much. Geetika, is Dr. Priya available?
Yes, sir. So for this session sponsored by Aris, and I would like to invite Dr. Priya Tiwari ma'am. She's a senior consultant Department of Medical Oncology at MIS Hospital, Gurugram. So it's over to you, ma'am. Dr. Priya? Priya ma'am, my voice is audible?
Yes. So I think that's the last session that we are going to have. I'll just start sharing my screen, okay?
Sure, ma'am.
Yes. So I think I'll just so a very important topic that needs to be discussed sometimes is an important drug which is actually very less talked about. Are the slides visible? So I'll just put it in the slide.
Ma'am, yes, it's can you please make it full screen?
Yes, yes, yes. Okay. So
Yes, it's
nimotuzumab is a drug which is anti-EGFR. It is more specific and has lesser affinity for EGFR receptors compared to what we know, cetuximab and panitumumab. But yes, the data is now evolving for the brain tumors, and Dr. Vijay Patil has done a lot of work regarding the head and neck cancer, and we'll just discuss a study here in the head and neck cancer sphere. So, a randomized phase 3 trial comparing nimotuzumab plus cisplatinum. So, this is a space where you give chemoradiation using cisplatinum and radiation in head and neck cancer patients. So, in this arm, nimotuzumab was added to one of the arms. So, this was a trial schema, 754 patients, 1:1 randomized. So, one was simply a chemoradiation arm with cisplatin, and the other was this nimotuzumab addition. And then subsequently the data was analyzed. So what we saw that the 2-year overall survival which was initially presented was 57.7% in the combination chemoradiation arm, and with addition of nimotuzumab it became 63.8%. So slightly better but not marked different at 2 years. Definitely the PFS were better. The 2-year PFS was 50.1% and 61.8% by addition of nimotuzumab with a p-value of 0.0044. And if we talk about the local control, again it was better, markedly better with the addition of this particular drug. So the authors at that time concluded that the addition of nimotuzumab to concurrent weekly CRT improved PFS, loco-regional control as well as DFS. So this was the combination where they gave weekly cisplatinum 30 mg per meter square. So they also established that this combination provides a novel alternative therapeutic option to a 3-weekly schedule of 100 milligram per meter square. So we all know that the 100 milligram per meter square of cisplatinum is something which is the standard of care but poorly tolerated. Weekly cisplatinum is something that we are all comfortable in using, but the addition of nimotuzumab here showed that yes, the results of weekly cisplatinum can be further improved by addition of nimotuzumab, especially in terms of PFS and DFS. However, what about the long-term controls? Okay. So again, the long-term controls were actually published, and that is what long-term overall survival results were published, and this is what we are going to discuss here in this particular slide set. So nimotuzumab in the doses of 200 milligram were added to the cisplatinum and radiation, and the primary endpoint was 10-year overall survival. So this was again this was that part of the randomized trial where we now going to see the long-term 10-year overall survival rate. So the median follow-up was 8.86 years. The primary site most commonly being the oropharynx, and the only 24 cases were HPV positive. So majority of patients were actually HPV negative. Now what they found was that the 10-year overall survival was 22.5, but by the addition of this drug, it became 33.5 with a p-value of 0.044. And median overall survival also improved 2.78 years in the CRT arms, and by the addition 3.69 years. So especially for the patients who had HPV negative, it was 1.8 versus 2.48. The long-term adverse events were captured in 380 patients, and no statistically significant difference between them. So we know that the HPV negative cohort is a group where we see that the HPV positive cohort is supposed to have a better outcome. HPV negative cohort is something that we know has a comparatively compared to HPV positive has aggressive course, but here we do see a benefit by this addition of this particular drug. So the addition of nimotuzumab, the author's conclusion was the addition of nimotuzumab to weekly cisplatinum leads to improvement in the long-term overall survival in locally advanced head and neck squamous cell carcinoma without any additional increase in the late-term adverse events, and these results are largely applicable to HPV negative patients. So this is what it was. So I think that will be all. Thank you.
Hello.
Hello.
Hi, Dr. Priya. Are you doing HPV testing before resorting your patients to biomab, or is it like for everybody as of now?
No, we are not doing it based on HPV testing. No.
Okay. Thank you so much for your presentation. Deepika, can we close the session for today?
Sir, please give it to closing remarks.
Okay. So we come to the end of day one. We had good discussions and deliberations on the topic, and thank you all the speakers for being there and discussing your viewpoints. And I think everybody all of us have got wiser. Day two is tomorrow. We start at 7 p.m. and discuss the remaining sessions. Be there for those as well. And till that time, it is goodbye from all of us and have a great evening ahead. Thank you.
Okay, thank you so much, Dr. Rajat and Dr. P, and all the pharma companies and delegates to join for today's session. Please join us for tomorrow's session also. So, good night, everyone. So, tech support, can you close the meeting?
Okay.
So, thank you so much, Bhavya, for today's